Welcome to the Speaking of Women's Health podcast. I am back in the Sunflower House and I am your host, Dr. Holly Thacker. And on this day in June of 2023, we're going to talk about female hormones and hormone therapy and issues and things to expect if you are starting menopausal hormone therapy. And not all women need or want hormone therapy. In fact, as of right now, even though it's not available in pharmacies yet, but soon will be, we finally have the candy neuron inhibitor Veozah, Veozah, which is a 45 milligram once a day tablet that's a non-hormonal treatment for hot flashes. And I have several of my patients who can't or won't take hormone therapy. Maybe they're undergoing active breast cancer and having treatments and having some bad hot flashes. So that's really exciting. And one of my last podcasts on breast cancer survivors, I was talking about the designer hormone Duave, which is conjugated estrogens with beta-doxyphene, and that had been off the market and not in production by Pfizer during all of the pandemic. And as of June 6th, which I think was the date my breast cancer survivor podcast posted, it was back finally in the pharmacy after promising us this for some time. And that's a good hormone option for people very sensitive to progestins or progesterone, people wanting a low dose, maybe people that are at risk for breast cancer, those with endometriosis. So what are hormones? Well, they are substances that are produced by the endocrine glands in the body. And hormones control the actions of certain cells and organs and processes in the body. So the female sex hormones are estrogen and progesterone and testosterone. Actually, we women have more testosterone on a gram per gram basis than estrogen. It's just that men have 10 times the amount that we do. Now, estrogen is a female sex hormone that stimulates and maintains the secondary female sex characteristics. And estrogens can be natural or synthetic. There are four human estrogens. Classically, E2 is estradiol, the most potent, the one that we judge all the others on. E3, estriol, is like a byproduct. It's pretty high in pregnancy and pretty weak. And E1, estrone, is more of a postmenopausal byproduct. And then estetrol, which is E4, is now available in a hormonal contraceptive, Nextstellis. And it's in studies right now as an estrogen option for menopausal hormones, and it appears to have less breast stimulation and less propensity to stimulate coagulation. So we do use either natural or synthesized hormones to treat both menstrual disorders, perimenopause, and postmenopause. So estrogen influences how the body absorbs and uses calcium, which is a very important mineral in the building of bones. And estrogen helps maintain healthy ratios of cholesterol in the blood. In general, women have better cholesterol ratios than men and less cardiovascular disease, although women catch up after menopause. So estrogen has effects on your overall health in both men and women. And men don't lose their estrogen at midlife like women do when they run out of eggs, because testosterone is converted into estradiol in men. So estrogen can affect cholesterol levels, blood sugar levels, metabolism, bone and muscle mass, circulation, the vascularity and tone of blood vessels, collagen production and moisture in the skin, and neuronal brain function, including the ability to focus and find precise words. So when hormone levels like estrogen fluctuate or are lower, they can trigger menopausal symptoms such as hot flashes and night sweats and trouble sleeping. And there is significant risk for medical conditions associated with estrogen deficiency like osteoporosis. If you haven't tuned into any of our prior podcasts on osteoporosis, both for our general audience as well as our CME that's free for doctors and nurses and registered pharmacists, please be sure to subscribe anywhere you subscribe to podcasts for free. And you can just scroll up or down and look at all the different topics and podcasts that we've had. So I talked about the three major forms of estrogen: E1 estrone, which is primarily postmenopausal; E2 estradiol, which is the most potent form of estrogen; and there's one hormonal contraceptive that has E2, which is Natassia, which is also the only hormonal contraceptive that's FDA approved to not just prevent pregnancy, but also manage abnormal uterine bleeding that goes along with perimenopause. And then estriol is a very weak form of estrogen during pregnancy. Sometimes it's promoted as a compounded vaginal cream to treat atrophy, but it's very weak and it's not any safer or better than just using vaginal DHEA, which is actually more potent because it's a hormone precursor through endocrinology. The cells of the genital tissue can uptake this precursor and make both estradiol and testosterone in the cell where it's needed and not affect the uterus. And some people have falsely promoted that estriol does not stimulate the breast or is therefore breast positive. But we know that estrogens, transdermal, oral, and especially conjugated estrogens, which is a mixture of 10 different estrogens, which was studied in the Women's Health Initiative in women without a uterus, actually reduces breast cancer risk even into the 70s, which is the 8th decade of life. So what role does estrogen play throughout a woman's life? Well, like all hormones, it's a chemical messenger. It tells your body when to start and stop processes and protein production and things that can affect your sexual and reproductive health. Puberty is when estrogen levels start to rise, and they lead to secondary sex characteristics like developing breast and the overall body composition, like the typical feminine curves. Now, the menstrual cycle, along with hormones made in your brain, in the pituitary, FSH, follicle-stimulating hormone, which your physician may order a test on, and LH, luteinizing hormone, as well as progesterone and estrogen, play a very important part in your menstrual cycle. And these hormones coexist in a very delicate balance to keep menstrual periods regular. Estrogen plays a role in ovulation, which is when your ovaries reduce an egg and then thickens the lining of the uterus, specifically the endometrium, the lining of the uterus, to prepare it for pregnancy. Endometrium. I'll never forget when my oldest son's teacher called me, kind of mortified. She wanted to know how my elementary-aged son knew what the endometrium was. Well, he's been to several of my medical lectures because when you're a busy mom of young children, sometimes you have to take them along with you for educational purposes. So pregnancy and fertility, very important with the sex hormone cascade. Estrogen peaks in the days that lead up to releasing the egg, and that's a woman's most fertile period. The egg lasts about 48 hours. At the same time, estrogen thins the cervical mucus, making it more hospitable to the sperm that have to swim through the cervical mucus to reach and fertilize an egg. So these estrogen-induced changes make it easier for a woman to become pregnant. Regardless of where you are in your menstrual cycle, the presence of estrogen makes it a lot more comfortable in terms of having a healthy, elastic, moist vagina. Because estrogen, as well as DHEA, which is from the adrenal gland and is a precursor hormone, helps keep the vaginal walls elastic and thick and lubricated and well vascularized with appropriate neuronal synaptic sensation. Menopause.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
It's a natural life event, and it's something that I've dedicated my career towards. And estrogen levels can fluctuate and then precipitously drop in perimenopause, which is the time right before menopause. And perimenopause can last for several years before the actual final menstrual period, which is retrospectively diagnosed as menopause. So once you've gone for 12 months without a period, which is usually around 51, 52, we can look back and say, oh, that was your last period. That was, quote, the moment you entered into menopause, which is a little bit of an artificial time, but it's still very important to date it. And I think some of our concepts about the absolute age of hormonal menopause, fertility menopause, menstrual menopause, sometimes they all coalesce in a woman at the same time, but not always. And not all women need to worry about contraception, but all women should be able to have been diagnosed with the time of menopause, because the hormonal age is actually more important than the chronologic age, because after 10 years of losing human estradiol without taking any hormonal therapy or replacement doses, in the case of a woman who has premature menopause or early menopause or surgical menopause, after 10 years, there are some irreversible changes in the estrogen receptors. And we know about ER alpha and ER beta, and there's probably another estrogen receptor. So when you have a decreased level in estrogen, it can lead to symptoms like hot flashes and night sweats, and resultant mood changes, and vaginal dryness, or even painful sexual activity called dyspareunia. And the primary estrogen in your body in postmenopause changes from the more potent E2 to the weaker E1. So what happens when your estrogen levels are consistently low? Well, low estrogen is often a telltale sign that you're approaching the change of life. And not only does low estrogen signify a fertility decline and a fertility problem if you're trying to become pregnant, but also a nutritional deficiency. And conditions like Turner syndrome, or Turner mosaic, which is instead of having the 46XX chromosome, some women have the 46X0, and that can also mean some hormonal insufficiency. So when you're low in estrogen, the bones can get thinner, joints can ache more, there can be complete temperature dysregulation due to the KNDy neurons and an area in the hypothalamus in the brain. Some people get headaches from the fluctuating hormone levels and trouble concentrating. Some women describe brain fog and word-finding difficulty. Others, especially those predisposed to mood changes and depression and anxiety, notice this to be more prominent. If you haven't heard my podcast on why women love chocolate and mood changes and neurotransmitter changes and how neurotransmitters are different than hormones, but how these two substances in the brain have significant interactions. And then, of course, up to 80% of women, when they lose estrogen, will have significant changes in the genitourinary system. And whether you're a breast cancer survivor or not, or have a friend or a family member who is, it behooves all midlife women to know what GSM is, genitourinary syndrome of menopause, and why it's important to treat this and what all the different treatment options are, hormonal and non-hormonal. So what happens if the estrogen levels in your body are just consistently high? Well, excess estrogen in your body can be associated with tissue overgrowth of the lining of the uterus, hyperplasia, with uterine polyps, with growths of uterine fibroids, also called leiomyomas, which up to 80% of women with a uterus have. PCOS is associated with excess estrogen, hormonal imbalance, and sometimes too much testosterone as well. Too much estrogen can cause flares of endometriosis, which is when the lining of the uterus is outside of the uterus. And levels may be high because you're just taking in too much estrogen in relationship to progesterone. Progesterone is made in the corpus luteum, which is formed after ovulation. And the main purpose of progesterone is to protect the uterus and prepare it to accept a fertilized egg, and if not pregnant, then shed naturally. When women are low in progesterone as they get older, they have heavier periods, many times have cramping and clots and flooding. But if you're a woman over 40 with any change in your cycle, any abnormal bleeding, it has to be investigated. Most of the time it's hormonal or anatomic, like polyps or fibroids that are what we call submucosal, right under the lining of the uterus. But occasionally it can rarely signify cancer or hyperplasia or precancer or even infection or endometritis of the lining of the uterus. So when your hormones are fluctuating, you may have a decreased sex drive. You may notice weight gain. Most women's major concern at midlife is weight gain, particularly around the waist and the hips, the muffin top. And when you are low in hormones and your body is stressed, or your body's stressed from any cause, many women have increased adrenal stress hormones, and that can lead to anxiety and weight gain and poor sleep and anxiety and nervousness. Certainly having your hormones out of balance can cause abnormal bleeding with an unpredictable timing, changes in the cycle. Actually, only 10% of women, if that, have a regular period that then just stops on a dime and then is associated with symptoms. Many women have sputtering off on hormones, too much, not enough, sometimes fine. And I'll see so many women who are having terrible symptoms when they made the appointment. And then when they get in, they're like, oh, this last month or so has been fine. Wouldn't you know? But even if you feel fine, it's still important to keep that appointment and get some anticipatory guidance and planning and get your questions answered. And I really think it behooves all women by age 40, certainly long before the symptoms may happen, long before the cycle may change, even if you are not worried about childbearing or you're not worried about periods or you feel great and you're just hitting your stride, eventually all women, if they live long enough, which thankfully most of us do, will come to the time in life where their ovaries are just done for business. They are not ovulating, they are not cycling, and they are not trying to prepare the body for pregnancy. So how do I know what my estrogen level is? I get this question every day. Well, you can get an estradiol level, which can measure hormones. You can get total estrogen levels, which are usually a much longer, more expensive test that can measure E1, E2, and E3. And there are many labs that can do this test, but hormones are measured in picograms. And picograms are very small amounts, so not all labs are as well equipped. And one of the biggest problems I see is the popularity of biotin or B7 as a vitamin promoted to help the hair and nails. It probably helps the nails more than the hair, but at high doses, even just average doses, it can really interfere with a lot of blood work, including hormonal levels, estrogen, thyroid, and several cardiac tests. So the FDA did come out with a warning several years ago. And on our order sheets, even though I don't think everybody always reads all the fine print, but you should, it clearly states you should be off biotin for at least 72 hours before getting blood work. And I have seen women that have normal estrogen levels around at least 40 to 50, which is like closer to what a man has, like a low menstrual level, clock in levels of over 2,000 just from the interference of biotin with a lab assay. So what's progesterone? Well, as I mentioned, it prepares the uterus to receive and sustain a fertilized egg. But when pregnancy doesn't occur, which is most of the time, the endometrium then sheds normally during the menstrual period. But if conception occurs, progesterone levels increase to support that pregnancy. And it also helps to support breast development and lactation. And progesterone is actually stimulatory towards the breast. So generally speaking, the best time to do a breast exam is right after your period or during your period when the progesterone levels are the lowest and your breasts are the least stimulated. And the worst time to do it or to get a mammogram is when progesterone levels are the highest, which is that week or two before your period. Now, your adrenal glands and placenta, especially the placenta, can make progesterone. So what does progesterone do for the body besides helping to regulate menstrual bleeding and help prepare for pregnancy? Well, in many women, it improves mood and sleep. It can help with blood pressure, and it supports thyroid function. And as menopause nears, the ovaries do reduce most of their production of progesterone as well as estrogen, but do continue to make testosterone or androstenedione, which is a precursor to it, made in the stroma of the ovaries. So even once you run out of eggs, your ovaries can still be hormonally and metabolically active. In fact, for women who don't have any gene mutation that increases their risk of breast and ovarian cancer, keeping your ovaries intact to age 65 actually has a survival advantage. But if you're someone who does have a gene carriage rate, such as BRCA or CHEK2 or BRIP1 or PALB, there's several different genetic mutations that have been identified. If it's determined that your risk of breast and or ovarian cancer is high enough to justify removing the tubes in the ovaries, then doing that and replacing with hormones is the better option in terms of longevity and health. I would say that my medical opinion is that if you're going to have your tubes and ovaries removed because you're a genetic carrier, you should have the uterus removed because several of those conditions do also increase the risk of uterine cancer. And even if you're not a genetic mutation carrier but have to have your ovaries removed for another reason, I prefer in most all cases for the uterus to be removed, because then if you need menopausal hormones, which most women do, it's just estrogen alone, which is safer and cheaper and is associated with a reduced risk of uterine cancer. Now, there is some supportive structures associated with the uterus. It is a more involved surgery. Again, this podcast is not medical advice. You need to seek out information, but I've seen a lot of women who just follow the recommendations of the first physician they see, who many times isn't the one who's going to follow them longitudinally. So I do advise women to get all their questions answered and to get a second opinion. So some of the symptoms of low progesterone can include irregular menses, difficulty concentrating, more anxiety, more trouble sleeping, and even worsening of hot flashes, although estrogen is the primary driver in that regard. High progesterone levels typically don't have a negative impact, but in rare cases it could be a sign of ovarian or adrenal cancer. So how are progesterone levels tested? Well, there is a blood test, a PGSN or progesterone test, but it's most commonly used to determine ovulation and used for fertility. In most midlife women, getting a menopausal risk assessment. We don't routinely do it. If we're concerned that a woman does not have enough progesterone, we simply do an office endometrial biopsy or sampling, which for most women, especially if the vagina is not thin and the cervix is open, perhaps they've had a vaginal delivery, is usually pretty uneventful for most women and not too much more than a pap smear. Although there are exceptions, and the medicine misoprostol or Cytotec, which is used to prevent stomach acids from NSAIDs and aspirin-like medicines, actually has a side effect of softening up and opening the cervix. And so sometimes we give this orally or vaginally or buccally through the cheek for a day or two prior to a gynecologic procedure. So progesterone levels do fluctuate throughout your menstrual cycle. Levels definitely rise after you make an egg, and they really continue to rise if you are pregnant. And your healthcare clinician is the best person to help you assess what levels you may need and to follow you if you are indeed pregnant. Some women take progesterone supplements, and we frequently will prescribe natural progesterone in the form of prometrium, which is actually mixed in peanut oil, so you can't be allergic to peanuts. Sometimes we use this as a medical DNC to help regulate the cycle, and sometimes progestin-only pills are used as a non-estrogen hormonal contraception. They're not quite as effective as the combination estrogen and progestins, but it is important to understand these basic hormones. Now, the third hormone is testosterone, and although testosterone is thought to be a male hormone, it really is not. It's in both males and females, and women produce more testosterone on a gram per gram basis, and the ovaries produce both testosterone and estrogen and progesterone, and so do the adrenal glands. The ovaries make about 40 to 50%, and the adrenals make up the rest. Usually with age and muscle mass, testosterone levels decline over time and with age. There are many causes of low testosterone, such as surgical removal of the ovaries, causing at least 40% of the loss. Some medications like long-term glucocorticoids, so-called steroids or prednisone, birth control pills, especially with estrogen, reduce testosterone production at both the ovary and adrenal gland. Some antidepressants, adrenal failure, some hypopituitarism, poor nutritional status, and eating disorders like anorexia nervosa. Now, low testosterone may result in decreased sex drive, poor sleep quality, mood issues, and decreased muscle mass or difficulty maintaining muscle mass and muscle strength. So what's the management of low T in women? Well, we generally don't use them to diagnose sexual dysfunction, but we might use them to monitor if we're using off-label testosterone. Currently, the only evidence-based, FDA-approved indication for using testosterone is in women with hypoactive sexual desire disorder or female sexual dysfunction. But sometimes there is conditions like female androgen deficiency where women have some fatigue, maybe they have refractory hot flashes that aren't controlled with adequate levels of estrogen, they may have a lower muscle mass, and some general fatigue and lack of that verve for life. And if you're seeing a hormone menopause expert, many times with informed consent, going through all the options, we may recommend off-label testosterone. There are unfortunately no FDA-approved testosterone formulations for women. They're all for men, except there is one oral esterified estrogen with methyl testosterone. It was actually on the market even before the FDA was on the market, so a lot of insurances won't cover it because they say it's, quote, not FDA approved because it didn't have to go through the FDA. And that is esterified estrogen with methyl testosterone, which previously went under the generic name Covarix HS and regular Covarix or Estrotest and Estrotest Half Strength. But those brand names are not available. Very importantly, women should avoid intramuscular or pellet therapy, which is kind of all the rage. But women get male levels of testosterone, and many of them don't get enough testosterone or enough estrogen, just too much testosterone. And long term, that can cause some side effects and some virilization.
We'll be back after a quick break.
Have you ever experienced fitness failure? You know, you set a goal to exercise, you're all excited, and then you're not. Hi, I'm Dave. I host the daily 10-minute podcast, Walking is Fitness. Instead of an exercise goal, I talk about making a fitness promise. And every day you keep that promise, you add another link to a growing fitness chain. This is a podcast of action. You'll create a fitness habit, which eventually becomes fitness momentum, and then on to all kinds of good stuff. Check it out. Walking is Fitness, and let's take a daily 10-minute walk together.
Available oral therapies, as I mentioned, we've had that combined esterified estrogen with methyl testosterone. In general, transdermal therapies for testosterone are generally looked at as being favorable in that they avoid the liver, and there are various compounded testosterone creams and gels and ointments that can be used on the groin or the labia. But it's very easy to overdose on testosterone, and all the male products, the gels like Androgel or Testim, are all designed for men and have about 10 times what a woman needs. So women need 1/10 to certainly no more than 1/7 of the dose. And judicious monitoring, checking levels, within 3 to 6 months is recommended. And not all women get side effects like acne or oily skin. And sometimes these women feel terrific on testosterone and keep using too much. Most women will get side effects of oily skin or acne or a couple of chin hairs where they don't want them, and that inhibits them using too much. But not every woman is wired the same way. There are 2 non-hormonal FDA-approved treatment options for treating hypoactive sexual desire disorder in premenopausal women, and both work via the neurotransmitter pathway. Addyi, which is flibanserine, which I wrote about in my first book in 2007, was initially studied as an antidepressant, and it does help the mood and helps sleep, but paradoxically it flips on the sex drive, which many antidepressants turn the sex drive switch off or make it difficult to climax. It's taken at night, it's metabolized through the liver. Many insurances don't cover it, but if a person has commercial insurance, sometimes coupons and prior authorizations and other paperwork can be done to help make it potentially affordable. For women considering taking Addyi, they need to take it for at least 60 days at night to see how it's going to work. In general, if you take medications that go through the liver, like fluconazole for vaginal yeast infections, or you drink a lot of alcohol, or take hormonal contraceptives and other medications that go through the liver, you can raise the Addyi flibanserine levels, and that might cause lightheadedness and dizziness. The second FDA-approved medicine for hypoactive sexual desire disorder is injectable Vyleesi, bremanolitide, and that is given by injection. It takes a half hour to 45 minutes to work. It lasts for at least 16 hours, but it has to be given by a tiny injection. And usually it's dispensed in a box discreetly with 4 pre-made injectable injectors. It can cause a lot of nausea and sometimes headache, so I usually advise women to take the first injection when they're very sleepy right before they go to bed, with the plan to be with their sexual partner in the morning. Now, high testosterone in women can cause some problems, and it can be due to polycystic ovary syndrome, congenital adrenal hyperplasia, an androgen secreting tumor like thecosis ovariae. And symptoms of high testosterone can include worsening acne and oily skin, and hirsutism, which is the medical term for excess body hair, particularly on the face. Hair thinning and the androgenic pattern in the temporal area top of the hair, the typical male pattern balding, can also happen and is called female patterned hair thinning. development of very masculine characteristics such as an enlarging clitoris and a decrease in breast size and a deepening of the voice and irregular periods and infertility and insulin resistance or syndrome X. So management of high testosterone in women depends on what the cause is, and we may use medications and lifestyle changes, weight loss or weight loss therapies, if PCOS. Metformin, also known as glucophage, is used for diabetes. It's also used in women with insulin resistance or PCOS, but many times intermittent fasting and dietary changes can make a significant difference. And substances such as the plant-based substance berberine has become very popular. There's also expensive injectable and oral medications that help with diabetes and weight loss. And if you haven't caught my Memorial Day 2023 podcast on calcium and cholesterol and how to be less sweet, we cover a lot of the things that make you less sweet and help treat insulin resistance. And we do have some great podcasts on weight loss. Sometimes hormonal contraceptives are used for women who desire contraception, regular periods, protection of the uterus, as well as improvement in skin and hair. I certainly get a fair number of referrals from dermatologists who are treating women for hair thinning and acne and hair and skin concerns for prescription hormonal contraception or menopausal hormone therapy if they're postmenopausal. Now, spironolactone is a diuretic that also has some anti-androgen effects at the skin level. It blocks the active DHT, dihydrotestosterone, at the skin level. Occasionally, very low doses of glucocorticoids, which are prednisone-like medicines, are taken by mouth to suppress the adrenal glands, which reduce testosterone levels. And weight loss with healthy eating and exercise definitely improves menstrual cycles and reduces insulin resistance, just like intermittent fasting. And there are various hair removal products, such as prescription Vanica. There's shaving and waxing and plucking and laser, which may be permanent. Most of these are considered cosmetic and are out of pocket, but occasionally if they are induced from a medical condition, sometimes there can be some insurance coverage. With laser therapy, if you have the same color hair and skin, it's not as much of a differential to be able to remove permanently the hair. So it's best done if someone has dark hair and light skin, or if they have dark skin and light hair. Certainly, there is also electrolysis, but that can be very time consuming. And getting on a great skincare regimen with the right exfoliants and toners and agents, from salicylic acid to retin A and other skincare products. If you haven't listened to our terrific podcast on skincare with the skincare esthetician Lori Skarsko, please go back and listen to that one. In fact, I think I need to listen to it again to get all those great tips. And talk to your physician or nurse practitioner if you're experiencing problems with estrogen, progesterone, testosterone, or maybe it's a neurotransmitter problem, or it's a combination of other things. Could be a vitamin deficiency, could be lifestyle choices. A lot of these situations all converge at midlife. And our goal is for women to be strong and be healthy and be in charge. And you've been listening to the Speaking of Women's podcast with your host, Dr. Holly Thacker in the Sunflower House. I'm the Executive Director of Speaking of Women's Health. And for more information about our wonderful free digital program, please go to speakingofwomenshealth.com. You can sign up for our free newsletter. You can download free treatment guidebooks like on menopause and perimenopause and abnormal hair thinning, osteoporosis, so many different topics. And if you're so inclined to support our nonprofit, we would really much appreciate you to go on speakingofwomenshealth.com and hit that donate button. And please subscribe to our free podcast wherever you listen to podcasts, like Apple iTunes, and Google, Stitcher, Spotify, Podbean. There's so many places that you can get free podcasts. And give us a 5-star rating, because that helps us move up in the ranking. Looking forward to meeting you back in the Sunflower House.